Hello docs, this is from Professionally Integrated. I want to take a time a little bit to discuss in particular one piece of research that was published October 2016 in JMPT. On guidelines, in the title of the paper is The Treatment of Neck Pain, Associated Disorders, and Whiplash Associated Disorders, a Clinical Practice Guideline. First, I want to say I appreciate any author who publishes a paper. I've published a couple studies myself. I'm in the works of doing others, and I can tell you it takes a lot of time and energy, so kudos to everyone who did this paper. I respect it. I respect the work that you did, but I also have a couple of problems on how this doesn't really relate to my practice, and honestly, I don't think it really relates to the science in the last 20 years. Here's a little bit of my problems with guidelines as it pertains to neck pain. If you're a member of Professionally Integrated, I hope you're not using neck pain as a diagnosis. To me, as a doc, I don't know what that means. If a patient comes in after they got stung by a bee on the neck, how do you expect them to say what happens? Or what it feels like? I have neck pain. What does that mean? What about a patient that I've seen that had a fracture in their upper cervical spine? I've had a couple with significant instability with fractures and tearing, and you know how they came to my office, what they said? They had a little bit of neck pain. Do I put those patients in the same group and lump everyone that comes in with pain? That doesn't make sense. Some people have cancer and their first sign of it is neck pain because maybe it's bone cancer. Now, I'm not here to make light of cancer or sprain strain, but what I think has to happen in the healthcare community is we have to start following up with what the research is telling us on how to help patients. Guidelines are just that. They're to guide the provider into telling us what's wrong and to giving them an appropriate treatment plan. But if someone comes in, like in this study after a car crash with neck pain, I don't know what that means. Now, the biggest problem that I have with this study, and no one has really mentioned it yet, is where this neck pain is coming from and how they came to certain parts of the analysis. So let me just read to you this here. In their analysis, they want us to break down how they got to a certain area. Now, let me read to you just a little bit here. Their guidelines they got from 2000 to 2010 Bone and Joint Decade Task Force on Neck Pain and its associated disorders, their classification of NAD, or neck pain associated disorders. Grade 1, no sign or symptoms suggestive of major structural pathology and no or minor interference with activities of daily living. Grade 2, no signs or symptoms of major structural pathology, but major interference with activities of daily living. Grade 3, no signs or symptoms of major structural pathology, but presence of neurological signs such as decreased deep tendon reflex, weakness, or sensory deficits. And grade 4, signs or symptoms of major structural pathology. Now here's my problem, docs. I haven't found the definition for structural pathology. I don't know what that means. So if I take an x-ray of a patient and they have a kyphotic neck or a loss of the cervical curve, to me, that is a sign of a structural problem. Does that mean they are no longer grade 1 through grade 4 because they're all looking for some structural pathology now? Are there studies, and if you're a member of Professionally Integrated, you know that a loss of the cervical curve and or a cervical kyphosis is a structural problem that can and will lead to pain both in the short and the long term? So what happens if I x-ray this patient and they have that? Does that mean this whole paper does not relate to my patient? How about if I do a flexion extension x-ray or a digital motion x-ray? and I see that that patient has instability, meaning on flexion or extension, they have either over 3.5 millimeters of translation or over 11 degrees of angulation, which could be indicative of some ligamentous problem. Are ligaments not part of our structure? If we tear our ligament, does that mean they lost or did not lose some structural integrity? In my opinion, in my clinical experience, as well as the other studies that I go over on this site, clearly say that this is a significant structural injury. So what patients do we put into this guideline? Do we just put in patients that either one, they come in, they're in a crash, we do an x-ray, they have complete normal cervical lordosis, all their ligaments are intact, and they have a little bit of muscle pain? Or is this suggesting that we don't even x-ray them to find out, and then we can lump everyone into having pain? What about some of the studies to show that car crashes can damage capsular ligaments? Is that a structural problem? Does that mean we should only treat them for a small period of time? Now, the other problem is when they talk a little bit about if there is a structural pathology and they're in that upper NAD category, does that mean, and it says that we should send them to a physician? Well, chiropractors are considered physicians. What physicians should we send them to? Back to their primary care? Now let's take a look at what those options are for them. So let's say they have a reversal of the cervical curve or instability, and we send them to their primary care. Are they going to get drugs for that? Are they going to get surgery? Does that have better outcomes than what we have to offer in our office? In my opinion, in my clinical experience, I'm going to say no. Now, can we give them the option to say, hey, you can see a surgeon or you can see a physiatrist for pain management? Give them the options. But I have a big problem with these guidelines that have come out recently saying, hey, if your patient has back pain or neck pain, this is how you should treat them. That doesn't make sense to me. Okay, I want to know why they have neck or back pain or headaches or dizziness. What is it coming from? Where is it coming from? Let us raise the bar on healthcare so we can help more people, so we can help more patients. But this whole lumping everyone together with pain, that doesn't work for me. Do we treat someone that has an annular tear the same as if they went to the gym and their upper traps are sore and they have a little bit of neck discomfort? I really hope not. What if a patient has a kyphotic angulation and you compare it again to the person who worked out and their neck is a little tight? They both are going to come in and say they have neck pain. But what are the long-term and the short-term outcomes of those patients? What are the treatment options for them? So, doctors, I'm asking you to just be very cautious on following certain guidelines when my opinion is the diagnosis is 20 years old. The research doesn't support this anymore. Take a look at this website. Take a look at what the science is showing us. Disc pathologies, kyphotic angulations, loss of the cervical curve, abnormal vascular supply due to some structural abnormalities that can lead to pain. Those are problems that can have pain, not just let's lump everyone together as neck pain. So I hope you use this site to help you increase your knowledge and information, and you can relay that information to the patients to help them understand what's wrong. But let's start getting them out of neck pain and back pain and headaches, and let's start doing our job as providers to find out what type of pathology they may or may not have, and then send that patient to the right place and give them the right treatment and protocols. Thanks a lot, and thanks for watching.